Um, Welcome, Sharon Denny, who is at the AFTD, and we'll talk a little bit more about what that means and the support group that they facilitate each month specifically for folks who are caregivers of those with ALS FTD. And I am going to, sorry, I'm making her a, where did you go, Sharon? Here, I'm making her a presenter, a host, so that she can do whatever she wants to do.
Excellent. Well, thank you. So it's really nice to be with you. Thank you for the invitation. I do have some slides that I'm going to share with you just as a way that I started to organize some of my thinking, but I want to make sure that you all feel we can be informal, and I want the presentation to be as helpful as possible to the things that you may be interested in or issues that you may be aware of that affect others who've been coming to the group. And so Anne has promised me that she will also look and watch for items in the chat or questions that we might want to bring up. Barring anything that you think of along the way, I'll make sure that we have time at the end to have questions and discussion further. So let me start by sharing this up, and we'll keep our fingers crossed. So hopefully you're seeing my full slide. And I wanted to focus our time today a little bit on information about FTD, but then also on specifically some of the care and support needs, which, as Anne mentioned, we have come to learn and understand more through one of the specific groups that we're offering. So if I can get this to move forward. Okay, I wanted to just start by telling you a little bit about frontotemporal degeneration. So frontotemporal degeneration is a type of dementia. And dementia or neurodegenerative disease is a really complicated field across the board. And so there's a lot of overlap, but also many distinctions between some of the different subtypes of dementia. And so FTD is recognized as the leading cause of dementia in people under the age of 60. And it specifically affects the frontal and temporal lobes of the brain. So the frontal lobes would be if you took the palm of your hand and really put it on your forehead. The frontal lobes are behind that area. The temporal lobes are literally on the side or above your ears where they are in that general area. I think that's actually a really good place for me to pause to say, I am not a physician. I'm not a neurologist. I am the Senior Director of Programs at AFTD, which is an advocacy organization in this type of dementia. So I've learned a tremendous amount, and I continue to learn a lot about the science and the research and the medical pathology and whatnot underlying these diseases. It's not my area of specialty. My specialty is actually in working with the individuals and the families who are affected by frontotemporal degeneration and through the advocacy work that we do. So it's a disclaimer to say that I'm bringing you good, solid information, but I do not have the depth on the medical side of some of the other folks that you may have heard about from neurology. So FTD affects these frontal and temporal lobes of the brain. What we know is that in neurodegenerative diseases, the brain cells begin to atrophy or die off because of the accumulation of abnormal proteins in the brain. And when there's atrophy in the parts of the brain that we're talking about here, it's different types of thinking skills and behaviors that are controlled by these parts of the brain and the circuits that become the symptoms that are associated with FTD. So FTD presents differently than Alzheimer's disease, which presents largely with memory problems, or than with some other types of dementia. So the symptoms that we see in FTD are directly related to the parts of the brain that are affected. So people may have changes in their behavior or what are seen as changes in personality. They may have changes in language or movement. And memory can be part of the picture overall, but is not one of the primary or hallmark symptoms. And as we said, many people develop symptoms when they're in the prime of their life. They're still working and active with family life, either children in the home, children emancipating and heading off to college. And so developmentally, with the younger age of onset, there are significant challenges that go along with FTD that are probably similar to ALS in more ways than similar to Alzheimer's disease, unless it's a younger onset. And it can be very difficult to make a diagnosis of FTD, and it takes on average about 3.5 years for people to get a diagnosis in some cases, not always. And we do see that diagnosis is getting better, but it can still be a lengthy journey to a diagnosis. So within the umbrella of frontotemporal degeneration, we see that FTD itself is not one disease. FTD, again, is an array of different subtypes of diseases that affect the frontal and temporal lobes of the brain. And so you may see different clinical presentations or different syndromes that are defined by the symptoms that are the earliest and the most prominent. The most common type of FTD is called behavioral variant FTD. There are also several types of FTD that are marked by changes in language or specifically changes in communication skills, and that's called primary progressive aphasia. There are 2 types of FTD that present first with changes in movement, either in balance or in walking or other types of movement symptoms, and they're known as progressive supranuclear palsy and cortical basal degeneration. And then, of course, the overlap between ALS and FTD, which is what we're going to look at more today. So just to give you a sense of some of the sort of common hallmark signs and symptoms of behavioral variant FTD, which is the most common of the subtypes of FTD, this is where people will often present with apathy or a loss of interest in activities and things that they used to previously enjoy doing. They don't enjoy them anymore. You may see people with behavioral disinhibition or losing the filter. People may lose that ability to self-monitor their behavior or their words or their actions, and they start to behave in ways that they wouldn't otherwise. So whether it's saying things that are uncharacteristically rude, or behaving in ways where you get too close to somebody, or you may go up and touch somebody's hair, which you ordinarily wouldn't do. A lack of the ability to kind of keep that filter in behaviors is one of the characteristic signs of behavioral variant FTD. The other thing that we see is a change in emotion. So people lose the lack of being able to connect with empathy to another individual or to family members. And sometimes this will show up as, not recognizing the seriousness of someone's illness, or not really sharing in the joy of someone at a cardinal moment in their life, whether it's a child going off to prom or the loss of a loved one, but that lack of empathy, an inability to take the shoes of the other person from an emotional standpoint is also characteristic of behavioral FTD. There's a loss of warmth and a loss of concern for others. We also sometimes see changes, compulsive or ritualistic behaviors, maybe single behaviors that people do over and over again, repeating with the same word or phrases, or hand rubbing or clapping. Sometimes people have routines that they'll do, more complex routines of walking the same route to the same place each day, but sort of a routine that becomes much stronger and can sometimes get in the way of other functioning. Sometimes people have changes in their eating habits or their diet. They may binge eat, they may eat one type of food, eat a lot of carbohydrates, or eat just one specific food. And then changes in executive functioning. So executive functioning is kind of the decision-making or the analytical part of our thinking that happens in the frontal lobes of the brain. This is where judgment, problem solving, organization and planning, all of these skills reside. So when there's disease in the frontal lobes of the brain, you see changes in decision-making, more difficulty following the ordinary steps of an activity, following a menu or a recipe, and a lot of times difficulties will show up on the job in terms of performance of work skills. The language types of FTD have a number of different symptoms that are possible, all different kinds of changes in terms of language, whether it's omitting words and not being able to sort of follow complex sentences, whether it's losing the meaning of words, as it would happen in semantic PPA, or in logopenic PPA, the third variant, speech is slow, grammar is intact, but there's difficulty in the impairment in the repetition of sounds and phrases. So each of these become very finely tuned, different ways of assessing and understanding specific types of symptoms related to language production or language reception and understanding. In the movement subtypes, you might see, these are also sometimes called atypical Parkinsonian disorders and progressive supranuclear palsy. There's a specific eye problem, an eye symptom where people are not able to have a downward gaze in the same way. They may have some instability in their walking or standing. There may be stiff movements. Sometimes these movements do look like Parkinson's disease, but they aren't. They're actually caused by a different pathology. And then cortical basal syndrome is also one of the movement disorders where people have very slowed movements or a lack of movement. They may also have some limb apraxia, where there's a loss of ability to execute common and well-known, well-done behaviors and fine muscle movements. So these two are very often also diagnosed or identified by a movement disorder specialist rather than the neurologist, a cognitive behavioral neurologist that might see others. A couple of things about medications in FTD. So right now there are no FDA approved treatments for the symptoms of FTD. So symptoms require adjusting the environment the person lives in, looking at environmental interventions, looking at behavioral interventions, certainly using a lot of support. There are medications that can be used off-label for some of the symptoms of FTD, but what we know is that the non-pharmacological interventions tend to be more effective. Very often people with FTD are prescribed Alzheimer's medications, and we know that's a risk in that the Alzheimer's medications are most often not going to be helpful, and in some cases can have negative side effects. So there's considerations in the medications used. There's a particular type of antidepressant that's the most common first choice of medications, and they're called the SSRI antidepressants that are used most often. Sometimes the atypical antipsychotic medications are used for some behaviors. And then again, some of the common benzodiazepines that are used for agitation or anxiety may be helpful for some folks, but also can have some rebound effects. And so using the medications in FTD has to be really carefully calibrated and worked out with a doctor who knows FTD and works really closely with the individual and their family. But the challenges for treating the symptoms of FTD are significant because there are limitations in what medications can help with. So what I wanted to do is just give a couple of fast facts and an overview of FTD, and then we'll see how that relates to what's known about ALS. And so in FTD, we know there's the best estimates right now are that about 60,000 people in the US are diagnosed with FTD. And so that would be about 15 to 22 people per 100,000 folks. And this is a statistic that's often used by epidemiologists when they study disease. And I mentioned that FTD is the most common form of dementia for people under 60. There's a lot of variability though. So there's a tremendous amount of we call heterogeneity within the frontotemporal degeneration disorders. So some people may be diagnosed as young as 20, in the early 20s, although it's very, very unusual. And similarly, people might be diagnosed with FTD as much as 80, but the average is in the middle. And so it's most common that people are diagnosed with FTD between the ages of 45 and 60. And then FTD occurs equally in men and women. And I mentioned it is difficult to diagnose. So FTD is often misdiagnosed first as Alzheimer's disease or depression or Parkinson's disorders, or very often psychiatric conditions. And it does take still about 3.5 years to get a diagnosis. In terms of the genetics of FTD, what we know now is that about half the cases of FTD are sporadic, where there's no known family history of FTD or another neurodegenerative disease. But in about 30 to 40% of cases, there is a family history of either Alzheimer's disease, FTD, Parkinson's or one or the other, or ALS or another neurodegenerative disease. And about 15 to 20% of cases of FTD are inherited through a specific mutation that can be identified. And there's a number of known mutations now in FTD. So compared to Alzheimer's disease, this is a higher percentage of people who have an inherited form of FTD. And as you'll see in a minute, it's a higher percentage than in ALS as well. The life expectancy of folks with FTD is on average 7 to 13 years. And that's from the time that symptoms start. But the range, again, is very wide. So some people live a shorter time, have an accelerated progression, and might live 2 years or less. And then some people may live more than 20 years. So within this umbrella that we call frontotemporal degeneration, there's a great amount of variability. And then if we pull up some information on ALS, and again, I'm not the expert on ALS, but some data for comparison is that there's about 30,000 people in the US who are diagnosed with ALS, or 5.2 cases per 100,000 people. And then as age increases, there's a higher percentage, a higher proportion of folks who may be diagnosed. And the age of onset that's most common for ALS is between 55 and 75. There's slightly more men than women who are diagnosed with ALS. And that a diagnosis for ALS often takes a year to confirm and to be finalized. And then 95% of cases of ALS are sporadic, where there is no family history that's known, and then the percentage of hereditary ALS would be 5 to 10%. Life expectancy reported to be 2 to 5 years from diagnosis, but again, there's variability in that. And then less than 50% of people survive 3 years with ALS, and 10% surviving after 10 years. So there's some of the variability that you can see in both of these diagnoses. And I'm sure you guys are familiar with the ALS presenting symptoms, but just in terms of comparing to FTD and where we're looking at really the motor presentation versus more the cognitive behavioral presentation, the symptoms that you see here are, I'm sure, very familiar to you. And the reference that's here is one of the resources that I would mention to folks who want to know more. Our organization did a webinar in 2019, bringing the ALS FTD experience into focus with a woman named Beth Rush from the Mayo Clinic. And this is another really good resource on the overlap between these disorders if folks are interested. So let's talk a little bit about the overlap. In 2011, after a lengthy hunt for a common genetic factor, researchers discovered a mutation in a gene that was responsible for some cases of FTD and some cases of ALS. And this research finding has really challenged people's thinking that ALS was purely a movement disorder and that FTD was purely a behavioral or a cognitive form of dementia. And so after having watched and noticed natural history studies where there seemed to be families that had experienced symptoms of both disorders, the scientists were able to identify a common gene, which is known as C9orf72, that is responsible for some cases. It's also started to change our thinking about how these two diseases may be related to each other. So ALS now increasingly is recognized as a spectrum of different subtypes and disorders, as is FTD. Right now, the most common way that these two are referred to is the ALS frontotemporal spectrum disorder. And researchers are really working hard to try to understand better how the symptoms overlap and what the molecular basis of the disease is. So certainly the symptoms of muscle weakness and atrophy, and then behavior and personality changes and language changes present some really specific challenges that people face. So in terms of the overlap, and this is an area of a lot of emerging research. And so the scientists continue to study and are learning more about the overlap all the time, which is really important for us to understand both from the FTD side and from the ALS side. right now, what's understood is that about 50% of people with ALS or motor neuron disease have thinking or behavior changes that can be measured, so of some significance. And then up to 20% of people with ALS and MND develop dementia. And most of the time, those characteristics look like FTD. Less is known, though, about how many people with FTD develop motor neuron disease and ALS. So if you think about the epidemiology that I mentioned before, right now we see FTD as also a pretty uncommon type of dementia, with about 60,000 people in the US as the best estimate. We do think that's an undercount, but because diagnosis is still challenging, we don't know how many people have FTD. And then with ALS being about half as prevalent, again, it's really important that we begin to understand more, how do these two diseases interact with each other? What is the significance and the impact of the C9 mutation that is responsible for both of those disorders in some families? And so this is an area where it's really, there's a lot of brisk research, and it's an area where we really do have reasons to want to understand better. So some special considerations in care and support, either disease by itself would be really difficult, but putting them together really exacerbates the challenges for people who are diagnosed and for families to provide good care and providers to provide good care as well. So what we know is that when both diseases are present, the symptoms evolve more quickly and a person's lifespan is shortened. It's really necessary to carefully consider what the person's current abilities are, both in terms of cognitive functioning and physical and motor functioning, and be able to understand why modifications of what we're expecting are really important because of the ways that the two different disorders interact and the symptoms of the different disorders. It's really important to evaluate awareness and understanding. So within FTD, where cognitive impairment is involved, one of the things that happens is a person's ability to monitor their own behavior and assess their own behavior can often be impacted, not always. So we'll hear about there's a loss of insight in FTD on the part of the person who's diagnosed. And we talk with lots of folks who have FTD, and I can tell you there are a lot of people who have a level of awareness about the disease and what the symptoms are that they're experiencing. But many people do not. And so where FTD is impacting a person's ability to understand their health situation and their health conditions, it becomes even more challenging. And so being able to regularly understand and evaluate that level of awareness on the part of the individual with the disease is a really important factor in terms of being able to make treatment recommendations, being able to implement and support treatment recommendations. And that reduced level of insight means that very often for somebody who has those cognitive impairments, the best interventions are going to be really dependent on helping to shape the environment around that person, rather than asking them or expecting them to be able to make changes themselves in their behavior or in their level of understanding. The other thing that we know is that in ALS, there are standards of care for a number of the symptoms, and the progression of the disease is better understood really than in FTD, where there is no specific clinical care guidelines yet and no particular standard of care because of the variability and the range of symptoms that we're dealing with. But where this level of awareness and cognitive understanding is impacted because of FTD, it does mean that some of the things that are standard practice in ALS care become much, much harder for the individual with the disease, as well as for the family members. Because if there's a level of cognitive confusion, it makes a number of the interventions scarier, harder to understand, harder to go along with for the individual if they don't understand the reasoning for them. And so it's a real important factor to recognize the interplay between potential cognitive impairment and the movement, the muscle and the motor symptoms of ALS. So a couple of things that we always want to look for and want to be advocating for is certainly a multidisciplinary care team that can be working together to be watching for changes in symptoms, whether it's physical symptoms or cognitive symptoms, and careful monitoring of the symptoms And early intervention is really important for the comfort and the care of the individual with the disease, as well as for the understanding of the care partners and people providing care to be able to adjust expectations and ensure quality of life wherever possible. So again, the care partner is going to be really critical to making sure that the best possible care is arranged for everyone involved. The goal of the intervention overall is to maintain safety and quality of life. On the ALS side, it's being able to prevent excessive fatigue, maintain stimulation for function engagement. The FTD side, safety issues are sometimes very different in terms of being able to make sure the person is safe from impulsive behaviors that might jeopardize their ability to make, their ability to make decisions around their own safety, whether it's following traffic practices or not having access to weapons or guns if their judgment is impaired. So the safety considerations on both sides of the fence are going to be different, but both are important to monitor and be aware of as you go along. The challenges for the family are notable. I think the cognitive impairment in FTD adds a layer of challenge for family members because those symptoms are harder to understand. The symptoms of ALS are visible and are things that people can kind of see and work with. The symptoms of FTD very often are invisible and not well understood even by family members. And so a lot of the responsibility for helping to understand the disease, learn about the disease, and try to adjust for cognitive symptoms does fall to family and care partners, which makes the role of the care partner that much more challenging. And, people really, both for emotional reasons and for physical reasons, really can't provide care alone. So being able to identify and connect with the support that they need, whether it's an advocacy organization like ours or like the ALS Association and others, making sure that the resources available for medical care, for therapy, for follow-up cares are there, support both peer and professional. It's a really logistical challenge to coordinate all this care. And again, just mentioning matching the expectations. The last thing on this slide is there's a book that I was introduced to a number of years ago called Green Vanilla Tea. And this is written by a woman whose husband had FTD and ALS. And it's one of the most, it's very moving. It's not an easy book, but it's a very honest book about what these two diseases look like when they overlap and what the challenges were for their family for providing care and what they learned, and really is a journey of hope and love and remembrance that came out of their experiences. So I know that this is actually the best book that I've found on the overlap between the two disorders. So quality of life, of course, maximizing the inclusion of the person with ALS from the start in planning and care planning, and as you go along to the full extent possible, adjusting expectations, maximizing engagement, trying to do preferred activities differently. So on the ALS side, you all have had to learn to do preferred activities differently using adaptive equipment to be able to get around and increase mobility. On the FTD side, it means finding ways of accommodating the challenges of being too stimulated if you're out in a restaurant, between the lights and the sound and the noises, finding quieter ways of doing things, or finding other ways of adapting to some of the cognitive symptoms. So doing preferred activities, but finding creative ways to do them differently so that it's still possible to remain engaged with the community and with family. And then making sure that the needs of everyone in the family system can be surfaced and understood. So Anne had mentioned a support group that we have. We do have a national remote support group for caregivers of people who have FTD and ALS and are dealing with both of these disorders. And the group started in 2016. And later in that year, we had the opportunity to partner with some folks with one of the co-facilitators at the time was a woman from the ALS Association. And they did put together a poster presentation that drew from the experiences of folks in the group. And so I wanted to share some of that with you. This is one section of that poster. that focused on some of the issues that were discussed in the group and what the experiences of the members were. Now, these are care partners for someone who was diagnosed with FTD and ALS, so had reached that level where the cognitive impairment fit the criteria for FTD, as well as the movement criteria movement symptoms fit the criteria for ALS. The group set out to look at the unmet needs in support and education for this section of our community. And by no means was this the end of the conversation. This was actually early on in the trajectory of this group, but the symptoms, the issues have remained consistent, and we've tried to continue to address them over time in different ways within the group. So the challenges that people identified really revolve around the lack of the specific medical treatment and interventions for this combination of diseases, and how challenging that is for people who are facing them. When you come through one door on the ALS side and part of the equation is understood, you come through the other door on the FTD side and part of the equation is understood, but when you put them together, there's a whole host of unmet needs, both for the individuals, their families, and for the providers who are working with them. So some of the things that were often discussed and where shared support, problem solving, and strategies were really valuable to folks were around the genetic questions, which of course is always a factor of concern for folks, around managing hygiene or apathy, managing the physical symptoms and the cognitive symptoms, working with durable medical equipment. And I had mentioned earlier that very often people with significant cognitive impairment from FTD don't understand the need for certain types of equipment. And so their ability to cooperate with using that equipment is really hard, which adds additional challenges for the care partner, who very often the decision-making around this, when one doctor says this is the best practice we have, and the other doctor is not really sure because they're not experts in ALS, and it's the family members in between who are trying to navigate that decision-making. It's really a very difficult place to be. So the more that as a field, we can learn about the overlap and provide better resources for folks to make those decisions and to have tools to use with their families, that's an important part of the need here. The other thing that's discussed around a lot is that the progression is not typical for either disease. So the progression for folks with FTD and ALS is going to be different again from what the doctors on the ALS side know, and it's going to be different from what the doctors on the FTD side know. And so the field as a whole has a real opportunity to begin to look at what is this continuum between these two disorders, and what are the distinct and the specific things we can learn about progression, and what can we learn about providing care, because the kinds of questions that families have and that individuals diagnosed have are they are just not fitting into either specific model the way that we have them currently. And caregiver isolation was a big concern among folks in the group, compassion and caregiving, and then of course grief and loss, which we know in FTD is a constant part of the journey and the trajectory from the time of diagnosis. People are facing grief and loss. We also know that when you add the two disorders together, the nature of that on a day-to-day, week-to-week, month-to-month basis is really different. And so again, with those questions around progression, we've recognized a particular need to attend to emotional needs of grief and loss within this group. When the group first started, whether it was by virtue of folks who had found it or how long it had been running, or the individuals who had been waiting a long time for such a group, but the group members, the caregivers, lost 6 members in 9 months, which was a really challenging dynamic for the group as well, who had just come together and started to share support, and were facing really the aggressive nature of the overlap in new ways. So a couple slides on research, just to stress again how important this is, especially in this overlap area. What we see right now is that diagnosis and screening are done in parallel by different specialists who follow different care guidelines. And bringing that process together would be beneficial for everyone, because being able to identify early if FTD and ALS are coexisting, if the symptomatology is there for an affected person, is important for care for sure. The discovery of the C9orf72 mutation has spurred a lot of research, some of which is learning that where there is a mutation, where the mutation exists, the clinical symptoms among various family members could be very different. So within a family that has an identified C9 mutation, some people may have predominantly ALS symptoms, some people may have predominantly FTD symptoms, and some may have a mix of both. And so there's a lot to learn in terms of how the disease presents, even when it's tied to a single mutation. And that's an area of very active research that's ongoing. I mentioned earlier that we don't really know how many people with FTD are affected by ALS, and we need to understand that better by making sure that screenings become available on both sides of the equation, again, so that we can better meet the needs of folks, both those diagnosed and the family members, but also so that we can begin to change the system of how we approach care for folks within this spectrum of disorders. So understanding the overlap better will help us to inform, just knowing how to help people know what to expect and how to provide care and address the different symptoms that they may be confronting. How to maximize quality of life, of course, is the main goal for all of us. And then more research will continue to help advance the development of treatments. We are seeing in FTD some of the first clinical trials for some of the FTD disorders where there is a mutation that's been identified. C9 isn't quite there yet, but what's being learned in the other mutations is also feeding how researchers are thinking about potential treatments in the other identified mutations and different subtypes. So partnerships are really critical, and that's partly why it's great to be able to have a conversation with you all today at this level, but also to realize that there's a number of really important research initiatives that are working in this space. There's a network of 19 centers that are doing FTD research in the US, including natural history studies and clinical trial networks. And there are folks participating in those studies who have a C9 mutation and or who have symptoms of both FTD and ALS. So this is an area where we are capturing information and learning more for sure. The FTD Disorders Registry is something I would encourage you all to consider. I know there are ALS specific registries for research purposes. Anyone with potentially diagnosed with FTD and ALS or who would fit in that overlap area could certainly participate in the FTD Disorders Registry. That's something you can do from home. It's a database, it's a HIPAA compliant database. And so as research advances in the overlap, that's available for folks as well. And then just a year ago, our organization joined in a partnership with Target ALS that is a $5 million grant that's awarded 6 projects looking at biomarkers and treatment in the overlap area. And then a couple of slides about us. So AFTD's mission is to improve the quality of life for people affected by FTD disorders and drive research to a cure. We do it through research, awareness, support, education, and advocacy. In terms of the specific resources we have for help, we have a helpline. We provide disease education, some care management information. We do have some FTD support groups, both local groups as well as some national groups, which is what the FTD ALS group is. We offer respite and quality of life grants for people with an FTD diagnosis or any one of the subtypes. And then we have information on research, and specifically related to FTD and ALS, we have the support group again. We have the webinar that I mentioned, which is a really good resource. And then we also have a publication we do for the education of healthcare professionals. And we did one of these issues on the overlap between FTD and ALS back in 2018. That is largely still current. And so that's available both as an in-depth deep dive from the FTD side into the overlap, as well as the piece that's called What to Do About is a listing of bulleted tips that might be helpful for folks managing care. And I'm going to stop there and end the slideshow, and I would be happy to answer any questions that you have or see where you all might want to take discussion.
And I am going to stop the recording now. Say thank you, Sharon.